Kia koto and welcome everyone to this webinar. We've got a really good audience of around 85 people this afternoon. So thank you for joining us today. My name is Andrea Savage and I'm a Parkinson's educator with Parkinson's New Zealand. And it's my great pleasure to introduce to you this afternoon Dr Eloise Watson, neurologist. I'm very fortunate to work alongside Eloise in Wellington, where she works at Wellington and Hutt hospitals. Eloise is an early career neurologist. She completed a Neurological Foundation Chapman Fellowship in Sydney, Australia, developing an interest and expertise in neurogenetics, movement disorders, and mitochondrial diseases. She also runs a functional neurological disorders multidisciplinary treatment clinic. Alongside her clinical work, she is pursuing research in mitochondrial disease genetics and serves as a member of the Movement Disorders Society of New Zealand and Australia Executive. Today's talk focuses on women and Parkinson's. Although there are many similarities for men and women with Parkinson's, there are also many aspects that can differ between the genders, which may not be as well illuminated from research to date. This talk explores how research shapes our understanding of Parkinson's and explores aspects of Parkinson's disease specific and unique to women, including implications for our understanding of Parkinson's for patients and for optimising individualised care. So with pleasure, I'll hand over to you, Eloise.
Thank you very much, Andrea. Kia ora, everybody. I'm Eloise, as Andrea has said. It's a pleasure to be here today, and hopefully there are some things that are useful for people from this talk. It's actually a talk that I've given previously and I've updated, so there may be some content that some people are familiar with. I think I will just need to reshare my screen. Is that right, Lawrence? Yep. There we go. Can you see that okay now?
Yes, that's fine.
Cool. Alrighty, so we'll get underway. It's slightly curious speaking to an invisible audience, but I hope that you can all see me. So this, as Andrea said, this is about Parkinson's in women. And why do we need to talk about Parkinson's in women? I guess, is that advancing for you? Oh, yes, there we go. Now it is. So I think this is not specific to Parkinson's or indeed even to neurology, but is one of the reasons I think that that this talk is relevant. And if anybody's interested in the topic in general, this is a really fantastic book. It talks about the data that we use to inform the way that we approach designing our world, essentially, and how that actually we've had a systematic bias against having women represented in that research and in our design processes, which results in us having research predominantly about men, which then influences the way we think about, understand and design things. And that kind of goes from the shape of your chair. Car crash test dummies are all male, so the cars are designed to reduce injuries to a male physiology in a crash. The temperature of an office, working hours, so sort of everything across our world is based on data that's been predominantly collected by and designed by men, which just kind of reflects the way things are. But recognizing that also helps us to understand that it often means that men are living in a world that is kind of functionally designed for them, so an expectation of function, whereas women are living in a world where there's not kind of intentional design for women, and so they're constantly adapting. And I think both of those things are relevant. So it means that a lot of our data is male-based, but also that women have a paradigm of adapting to suit the environment rather than the expectation expectation of functionality of the environment for them. And I think that often influences the way women experience their symptoms and adapt to their symptoms. So both of those facts are kind of relevant. And also this book is just really interesting. There's also kind of in a slightly more neurological sense, we work in a male-dominated profession, although that is changing, and the entrance to medical school in our country is now around about equal, male-female. Historically, medicine's also been quite a paternalistic paradigm, and the combination of a male-dominated profession, so most of the doctors have been male, and do what I tell you profession, which is also changing, has meant that actually the ability for men to hear women's experience of symptoms, to parse that information and understand, and then turn that into an understanding of a presentation of disease, has actually been quite limited as well. This particular article, and I think this is a freely available article, but is also slightly depressing read, but very powerful, that's talking about two syndromes over about a century's worth of medical research, and kind of highlights this problem of a male-dominated profession and paternalistic paradigm, which is that men who were boxers were well recognised to have an organic neurological neurodegenerative syndrome of the punch-drunk boxer. It was recognised that recurrent head trauma in the context of boxing as a profession resulted in a neurodegenerative problem that nowadays we recognise as chronic traumatic encephalopathy, and which is receiving a lot of interest relevant to Parkinson's because it often has a Parkinsonian type presentation, but particularly for high performance athletes in football and rugby and American football. On the other hand, women who had been in abusive relationships were seen by many very well-meaning people over the same century, and considered, despite their repetitive head trauma, to have a hysterical, anxiety-based functional syndrome, until very recently, in the last few decades, neuropathological, so looking at the brains of these people post-mortem, showed an identical neuropathology. These were the same syndromes that were being recognised under different labels for men and for women. And that just partly represents the different way that people convey their symptoms, that people perceive their symptoms, and then that research and approaches to understanding disease have differed between sexes over time. So it's a slightly uncomfortable read, but a very interesting read, and provides I think, a really interesting insight into the way, none of these people intended to judge people differently, but there's lots of implicit biases that both men and women harbour, but that mean that having representation of men and women is really important. So we have both a male-dominated data in general, we've got a male-dominated profession, and we also have a male-dominated condition with Parkinson's disease. So the prevalence of Parkinson's disease is higher in men. And I've put this picture up, which is one of the early illustrations, or the earliest known illustration of Parkinson's disease by Gowers in an 1886 Manual of Diseases of the Nervous System. And I've put it up both because it depicts very nicely kind of a typical visual perception or image of Parkinson's disease. You can see that the depth length is not very long, the posture is leaned forward, there's a suggestion of posturing of the hands and tremor, and these are features that we recognise associated with Parkinson's disease. This image is also used a lot in medical education. It's used a lot in educational leaflet handouts for patients and caregivers, and for training purposes. And in fact, really recently, it's been looked at particularly, and this is found to be vastly disproportionately used as the image to depict Parkinson's disease in educational resources across a variety of fields. And I think that that's also important because when we think about learning about and understanding diseases, we learn all the information, but then we create mental shortcuts because we can't keep a dictionary actively in our brain at all times. And so actually having a visual or a mental heuristic like this that helps us to think about what Parkinson's disease is also subtly influences the way that we then adjust our expectations of when someone presenting with symptoms might have Parkinson's disease. Does it fit our mental heuristic? And if our mental heuristic is disproportionately one way, then it's less likely to fit if the person we're seeing in front of us doesn't sit exactly inside that mental heuristic. So I think it's an interesting image and an interesting thing to reflect on. Now, we all know that women are not small men. We know there are biological differences in anatomy. There's lots of differences in physiology as well. And when we're thinking about that, when we go through training, we learn about all the different internal differences that you can't see, as well as the external differences. One simple example is the amount of body water in men is higher, and the amount of body fat in women is higher, and the converse is true. When we think about using medications, they mainly are dispersed in our body water, but sometimes they're shifted into our body fat compartments. And if those compartments differ between men and women, then actually our medications probably need to be adjusted for men and women as well. But again, most of our data rests on studies that are done in men. And so drug dosing often comes from men and is then kind of adapted for women, but probably needs to be adapted in a more realistic way. As well as the differences in biology, there are psychosocial differences. So in our day-to-day lives, men and women tend to hold different roles and tend to have different priorities. And there's obviously been a lot of change in the way your typical household runs over the last 50 years in particular, but that's continuing to change fairly dynamically. Interestingly, although many more women are in the workforce, the vast proportion of household tasks and care tasks, which are really important, do still tend to fall to women. And that has a material impact on people's priorities. So it means that women, as well as having their work role or identity and their relationship role or identity, they often also have roles and identities as caregivers. And we know that has a pretty important impact on the way people seek care, seek treatment, and which treatments people are likely to accept. And so that also has quite an important impact for women with Parkinson's. There's also kind of broader differences in cultural differences in terms of worldview and life experiences and the way we tend to express our life experiences. And I guess that comes back to that idea of when you have a male-dominated profession, then hearing a narrative that's different to your life experience is slightly harder to parse and get the right information from. So I think all of those things actually play into the way Parkinson's can present and be observed and approached differently between men and women. This is an image here from a study done in 2019 looking at differences in Parkinson's disease presentations between men and women, and just showing that actually there's kind of slightly different things that tend to affect women compared to men, and really tells us we should be thinking carefully about particular things that are likely to affect men and women, as well as thinking about Parkinson's as a whole. And we'll talk in a little bit more detail about these things as we go through. One of the things that I found really interesting and really enjoyable to listen to when I was first preparing this talk was this podcast. And if people are interested, I would really encourage you to have a look at it. It came out of a slightly unusual setup. So before COVID, there was a couple of neurologists in America who ran a local Parkinson's group for women. In COVID, that group went online, and by virtue of going online, they were able to offer it more widely, and there was great interest across the state, and then across America, and then globally. Within the people attending that, what had become a regular virtual meeting, there were both the neurologists who were treating people, and this group of women with Parkinson's disease. There were also physicians, doctors themselves who had Parkinson's disease, although no neurologists who had Parkinson's disease. And then there were obviously a lot of women affected by Parkinson's disease. And over the course of the discussions that they had online, lots of questions came up pertaining particularly to women-specific issues with Parkinson's disease. And in attempting to answer a lot of these questions, it just became evident that there was a real dearth of literature, a dearth of evidence to help answer those questions appropriately. And so the neurologists who ran this group and some of the people who are affected by Parkinson's within the group came together to develop and write this paper. And so that's part of why I think it's such a fantastic piece of work, because it's really directed at the questions that came up from people who were directly affected, revealed some of the gaps that were important to attend to, and has got some really fantastic information. So the podcast is about 25 minutes and is really worth listening to. There's also a freely available published article that goes along with it by the same title that I would encourage people to read if they're interested. So we come from a background of, like I said, sort of male-dominated data, and we know that there are differences for men and women experiencing Parkinson's, and there's a dearth of data to help us understand women's experiences. But what do we know? So we know, like I said, that Parkinson's is more common in men, although the difference between men and women's prevalence of Parkinson's is probably smaller than we had thought. So it's probably more like 1.2 to 1.4 men to every woman. But there's been quite a lot of variability in the different populations. So we see that changes a bit from country to country and study to study. The difference between men and women getting Parkinson's disease has decreased over time. And it's age dependent. So the pictures in the top right here show incidence, the number of new cases that come up, and prevalence, the number of people who have a disease, in this case, Parkinson's. And you can see that in the earlier, can you see my arrow there? Yep. So you can see in the younger age groups, actually, men and women present have about the same incidence, and it's quite low in the younger age groups. And then you get into the 50s and late 50s, especially, and these male and female groups start to diverge. And then men have a much higher incidence and kind of post-retirement age. And the incidence is relatively lower in women at those ages, but then comes back to being closer together. And so the prevalence, the accumulation of cases, kind of mirrors that. In the younger age groups, there's a very similar prevalence of Parkinson's, and it starts to diverge around about that just pre-retirement age, and then diverges in older age and comes back closer in the very old age groups. So part of what that's showing us is actually the younger onset forms, which tend to be more genetic Parkinson's disease than the multifactorial Parkinson's disease, more likely to affect both sexes equally. Like I said, there's a lot of variability in the data, and so this is another example from Northern American countries where, again, you can see the increasing difference between females, which is in the left panel here, and males. As you get into the older age groups, there's a much greater increase in men compared to women with Parkinson's disease. So we know that Parkinson's is more common in men than in women. The mortality of Parkinson's disease overall is higher in men than in women, but actually the life expectancy for men is slightly lower than for women. And so if you adjust the mortality in Parkinson's disease for sex and age, actually women have a similar or relatively higher mortality from Parkinson's. And that's shown in this image here, that particularly in the younger age groups, in fact, females have a slightly higher odds of mortality compared to other women their age. And then that comes to being very similar in the post-retirement age group. Not sure if that's the appropriate term to use for the age range. And that the increased risk of death related to Parkinson's disappears by the very older age groups. So Parkinson's no longer has this particular effect on premature mortality in older age. What else do we know? Well, I was quite excited. This is recently published by a couple of people who work in Otago. And so I'm optimistic that there's going to be a PhD coming out looking at this. So this is talking about the distribution of estrogen receptors in the brain, which modulate lots of cognitive processes. And they are particularly highly expressed in the striatum, amongst other places in the brain, which is really relevant for Parkinson's disease. And it's particularly relevant for the way Parkinson's disease diverges in presentations between men and women, and also the kind of, if you like, chemically opposite conditions of psychiatric disease like schizophrenia also have sexually dimorphic presentations. And the expression of receptors is widespread in the brain, particularly in these basal ganglia areas, modulate lots of cognitive processes and also modulate neuronal survival. So we know that those striatal neurons are really important and are what is lost in Parkinson's. And we know that the expression of estrogen receptors is also dynamic over the course of menstrual cycle and premenstrual in the menstrual phase of life and in the post-menstrual phase for women as well. So I'm hopeful that these guys are going to produce some more papers that help us to understand that in a bit more detail and understand how the dynamic changes might be relevant to people with Parkinson's over time. So seeing that there's differences in the incidence, the mortality, and the dopamine receptors tells us that maybe the pathophysiology might be different for men and women with Parkinson's. And there's quite a lot of studies in animals and preclinical studies. It's much harder to do these studies in people for obvious reasons, but that suggests that estrogen is neuroprotective. So it helps us to produce, to release, to take up again what's not used and to turn over dopamine, which is the key chemical that's affected in Parkinson's disease. It's also important in the survival of the nerve cells, the neurons that make dopamine, and as well as helping to prevent loss of those neurons. When you do lose neurons, it helps the remaining neurons to adapt and to compensate for the neurons that are lost. So it's really important. It's got lots of anti-apoptotic, so that's programmed cell death, and antioxidant properties. It also has been seen in preclinical studies to inhibit the accumulation, to prevent the accumulation of alpha-synuclein, which is the protein that we know aggregates in the brain of people with Parkinson's disease. And it's got neurotrophic factors, that is, things that help nerve cells to survive, that help mitochondria to function and to reduce inflammation. There's differences in the way receptors are located in the brain and in the ratio of D1 and D2 receptors, which is quite important to some of the side effects from medications and probably plays into why men and women have slightly different responses to some of the medications that we use. And like I said, it's got important impacts on the way the circuitry in the basal ganglia and the nigrostriatal region that's relevant for Parkinson's is modulated. Those studies are a lot harder to do in people, and there are a lot more variables in humans than you see in the laboratory, and even in animals across a lifespan. The environment is a lot more controlled, whereas people, including women, have a lot more variables that come in that mean that being able to tease out a particular cause through study data is much trickier. But there is data that suggests that the total lifetime estrogen exposure may be associated with decreased Parkinson's risk. So people who have a longer period of estrogen production have a decreased risk of Parkinson's disease. But actually that gets a bit complicated when we think about when that's modified. So post-menopausal estrogen-only hormone replacement therapy after hysterectomy may be associated with an increased risk of Parkinson's, whereas people who go through natural menopause and then receive combined HRT don't have any increased risk of Parkinson's disease. So actually you can see really quickly that those two things are conflicting bits of information and are a little bit trickier to tease out. Is it related to the to combined HRT? Is it estrogen only? Is it the hysterectomy, which usually removes the ovaries at the same? So there's lots of different things that we need to tease out better there. And so this is an area where I think the research is particularly lacking and important, particularly because this time of life coincides with the time where most people are beginning to experience the onset of Parkinson's disease symptoms. and probably the timing and duration of hormone exposure and the association with sex hormones, and then the interaction of those hormones with genetic and environmental risk factors is important. But you can see that teasing out all those different factors takes a lot of time and a lot more research. So as well as there being physiological differences, there's probably differences in the way that we are exposed to things in life. And I was thrilled, coffee has a protective effect, and basically anyone that's a proponent of coffee is a friend of mine. Women tend to drink more coffee. Unfortunately, coffee is seen to be protective for men, but not women. But I still drink quite a lot of coffee. And coffee has been shown to have lots of other beneficial effects. Parkinson's disease risk is lower in male smokers than females. So even if you match for the exposure to cigarette smoking, men have a relatively lower risk of Parkinson's compared to women. That's not an endorsement of smoking in any way, shape, or form. Alcohol has a greater Parkinson's disease risk lowering effect in women than in men. Again, not an endorsement of drinking anything other than sensibly. Head trauma is something that has been clearly associated with causing Parkinson's symptoms in men, and is something that men are much more likely to be exposed to, both occupationally in boxing, but also through employment, where they're much more likely to be exposed to a risk of head injury, and also in sporting choices. Pesticides, again, the association is only seen with men, and that probably predominantly reflects occupational exposures in countries where it's particularly relevant. And you're probably aware that the MDS ANZ has recently been involved in making paraquat illegal in Australia, although I don't think that's extended to New Zealand, but certainly the position statement is that it shouldn't be available. And then anemia, interestingly, has an association with an increased risk of Parkinson's, particularly post hysterectomy, which is kind of counterintuitive. I think, so this is quite a recent paper looking at how we might make sense of that. And I think it's quite helpful that as a way to think about it, that although there might be slightly different risks at conception, they're pretty similar. But then as brains develop, there's some difference in the way male and female brains develop. And as there's sexual differentiation, so there's go through puberty and things, you start to see more differentiation of the brain through adolescence. And then people also tend to start to encounter more consistent differences in terms of lifestyle factors and environmental exposures. And you can see that the risks then might diverge over time. But all of these things help to give us an understanding of what factors might be relevant for development and interactions that might result in the way Parkinson's disease develops. Of course, our data is only as good as how we collect it, and I think it's really important to recognise that, like I said earlier, a lot of our literature is based around studies in men, and a lot of our access to health care differs by sex, particularly in older age, because men are much more likely, well, I say that conversely, women are much more likely to age with limited financial resource or in poverty and have restricted access, particularly in countries where insurance was required for access to healthcare, to have restricted access to specialist healthcare. And so I think it's really important to bear that in mind when we're interpreting some of the data. The difference in Parkinson's between men and women is different in different populations and tends to be more similar in Asian populations compared to European populations. And the difference has been decreasing in recent years, probably reflecting better study setups. But so the variation in prevalence that we see may reflect partly identifying people with Parkinson's. There may be a systematic difference in the number of women and the number of men who have access to and get diagnosed with Parkinson's. And we'll come to that a little bit later on as well. Like I said, social determinants are really important, particularly with age, as are health beliefs, insurance in countries where private care is the default mechanism, and access to care. And also, like we've looked at, different environmental risk factors, genetic risk factors. There's obviously also an important difference important relationship between the incidence, the number of people who develop Parkinson's, the prevalence, the number of people who have it at any given time, and survival. If people have a condition for a very long period of time, they stay in the prevalence data for a long period of time. If people pass away earlier, then they drop out of the prevalence data. And so those things are important to remember as well. This was the forest plot, this is called here, showing different continents and studies. Look at age of participants in studies, the study design that was used, the general income of the country, and didn't see any systematic differences that might explain the difference in Parkinson's disease prevalence. But they couldn't look at environmental exposures or access to healthcare or inequities in healthcare. And so those are factors they couldn't tease out. But I guess what they've seen is that actually over time, the difference in prevalence is less between men and women, and that varies a wee bit between country. But their summed estimate is that it's only about 1.2 men per woman, so a much smaller difference than is commonly thought. So that's thinking about when and where Parkinson's disease develops. What about when people present with Parkinson's disease? So men and women tend to present slightly differently as well. We know, or there's good data suggesting that women have a longer delay to accurate diagnosis, the specialist referral, and then have less specialist input. And that probably reflects a combination of factors, both the disease itself, differences in the presentation of Parkinson's in women compared to men, but also in from the individual, the different way that, or a tendency for women and men to report symptoms differently, to emphasize different symptoms differently, and to differentially prioritize health needs. And also, coming back to that picture of people with Parkinson's disease, that mental heuristic, differences in the way a doctor might perceive the likelihood of Parkinson's disease being the case, and a difference in the way the story might be heard and understanding or interpreting the symptoms that someone comes to their doctor with. I also mentioned right back at the beginning that men live in an environment of designed functionality, and women are actually typically in an environment where they're having to adapt to something that's not designed functionality for them, which then results in a tendency to just adapt and get accustomed to kind of always having to adapt. And that can mean that actually when symptoms of a disease come up, people tend to adapt rather than to recognize them as a problem straight off the bat. Also mentioned, there's a tendency for women to be more likely to have care responsibilities, and so tend to deprioritize their own needs in favor of people that they are caring for. And the prioritization of symptoms is often a little different as well. It's also much more common for women to go to a clinic appointment or to go and see a doctor without a spouse or other person as a support person. And that support person is both an important set of ears, but also commonly an important advocate, and can help to convey the story. Two different ways of describing something are easier to understand than a single one often. And so I think that can be an important difference for women as well. It's really important to note, and this doesn't just go for women, but when people don't feel their concerns are heard, they don't feel comfortable bringing it up again, particularly if they feel it's been dismissed, but even if they feel that it's just not being handled sensitively. And that's particularly relevant for symptoms that are really common for women with Parkinson's. Pelvic floor symptoms, mental health symptoms are really common symptoms early in the piece for women. If you feel uncomfortable the first time you talk about it, you're not going to bring it up again, and that's important information that's lost. That's, like I said, it's not specific to women, but it does contribute to a lack of specific treatment and dissatisfaction with care. And it's probably magnified in minority groups. There's not an awful lot of data for women, although that is improving, but there's even less data for people who are in other minority groups, and that's both in terms of sexuality, but also ethnicity. And so probably those inequities and that discomfort with care are magnified in other groups of people. I think this is a really interesting picture. So this is a study from over a decade ago now, and it's looking at how long it takes from onset of symptoms to seeing a movement disorder specialist, which is kind of the gold standard in care. And you can see, and it's broken down by the parts of the getting to see the specialist. So symptom onset, seeing your regular doctor, getting a diagnosis, and then getting to the movement disorder specialist. And at every step in that pathway, men's journey is quicker and women's journey is slower. And so that's really just reinforcing that idea that it takes a little bit longer to go to the doctor. It takes the doctor a little bit longer to figure out that that might be the problem. And then it takes a little bit longer to get to see the specialist. And so that results in taking about 2 years compared to just over 1 year to seeing a specialist from the point of symptom onset. So, that also tells us that there's lots of places along the pathway that we can make a difference to helping women get the right care early in the piece. I mentioned that this can relate to a number of factors, and the data from studies looking at differences in motor symptoms for women compared to men have a bit of variability, but there's probably a difference in the way men and women present in terms of motor symptoms, and that probably partly reflects those differences in the nigrostriatal circuitry, the picture of the receptors that I put up early on. So women tend to have more tremor-dominant disease. They tend to experience more facial masking. There tends to be less rigidity compared to men, and maybe slower motor disease progression, although that's slightly complicated by the fact that often Parkinson's disease is presenting in the perimenopausal time, and so the protective role of estrogen is lost during that time. And actually, once you get into the post-menopausal women, motor progression is probably not slower in women compared to men. Women do have a higher risk of motor fluctuations, that is going on and off, and having dyskinesias, extra movements, as well as lack of movement, stiffness and rigidity, bradykinesia. There's an increased risk for women of getting levodopa-induced dyskinesias, that is dyskinesias relating to Natapara or Cinemet, and that probably reflects some of those things I was talking about earlier, that women have less relative circulating volume, a higher proportion of muscle compared to fat, as opposed to men who have higher relative body water and more muscle compared to fat content. And so there's probably that probably results in levodopa, the main active constituent in Cinemet and Natapara, having greater bioavailability in women. But there are probably also some genetic differences in determining dyskinesias, these extra movements that can happen. Women also have a higher propensity for postural instability, getting unsteady, and for falling over. And that's obviously a really important cause, not only of injury related to the falls, but also of reducing activity and social isolation, because falls, we know, lead to reduced confidence with walking, lead to reduced activity, and so they have a really important impact on quality as well as quantity of life. And because women tend to have lower bone mineral density, and that's very much dependent on calcium during the menstruating phases of life, to get good peak bone mass, they're much more susceptible to osteoporosis in the postmenopausal period. So when women have an increased risk of falls, they also have an increased risk of fractures and complications that go on with them. So that's a really important area. It means that physiotherapy and maintaining activity is doubly, triply, quadruply important for women. This is information from a couple of studies looking at motor symptoms in women compared to men, and showing that rigidity is higher in men compared to women, and that instability is higher in women compared to men, and dyskinesias are slightly higher in women as well. Interestingly, a more recent study didn't show an increase in or a significant increase in dyskinesias for women, but did show increased dystonias and some increased non-motor features, anxiety in women and cognitive impairment in men. We know that non-motor features are also a really important cause of quality of life. They probably have a bigger impact for many people than motor symptoms. There's less information about non-motor symptoms in general, but we know that it has a significant impact on quality of life for men and women. This is just looking at, so the top panel is age, the next panel is gender, and then the interaction of age and gender. Cognitive function gets worse with age, is probably more challenging in men, and there's no interaction of age and gender. Doesn't disproportionately worse in one gender with increasing age. Anxiety, depression, autonomic dysfunction, probably so autonomic dysfunction especially increases with age. So that's our automatic systems like sweating, like bowel function, like blood pressure when we stand up. So those things do get worse with age. They all seem to be probably slightly worse in women compared to men, but only anxiety is worse for women with age compared to men. And then quality of life is affected across the board. Yeah, there's different domains of non-motor symptoms. And I think in this top picture, one of the things that I think was really interesting when I was thinking about this is the time of menopause, which is the time when, or the perimenopausal period, which is when many people are starting to develop some of the early symptoms of Parkinson's disease and coming to diagnosis, is actually a point in time where autonomic dysfunction is also occurring for other reasons because of menopause. People experience lots of thermoregulatory dysfunction. Sweats are like and hot flushes are like a defining feature of menopause for many people. And sweating, blood pressure variability, there's lots of things that can overlap from between menopause and Parkinson's. Probably a reason that women are not recognised with Parkinson's early as well. There's also a significant difference in the non-motor fluctuations. So just like motor symptoms can vary over time, non-motor symptoms can vary over time, minute to minute, day to day, hour to hour. And those fluctuations are greater, significantly greater for women compared to men. Sleep and pain, so can be differentially experienced by men and women as well. Are much harder to consistently measure. And this is just kind of a summary of some of the non-motor areas. So men and women both can be affected in cardiovascular area. Sleep and fatigue tends to affect women more than men, and men and women get kind of different sleep features. Men are more likely to have REM, sleep behavior disorder, and excessive daytime sleepiness, fall off to sleep with their medications or their disease, whereas women are more likely to experience restless legs and persistent daytime fatigue. Mood symptoms are quite consistently more prominent in women, particularly anxiety and depression, and are often attributed to other things rather than Parkinson's disease, and are probably, again, one of the reasons that diagnosis is delayed. Men are likely to experience more cognitive difficulties and perceptual difficulties like hallucinations or illusions, which become increasingly common over time and can in part be medication related. Gastrointestinal symptoms are experienced more prominently by men, although women tend to get swallow and constipation difficulties more than men who get drooling problems, which is obviously really socially challenging. Urinary dysfunctions affect both sexes. Sexual dysfunction is almost universally only reported by men, and that probably reflects a greater impact for men, but also probably some societal taboos around talking about sexual desire and sexual function for women, and so it's much less likely to come up as a problem or as a symptom of for women to present to their doctor unless it is expressly asked about. Pain is more common for women to experience, although both sexes do experience pain. Taste and smell and sweating tends to be more prominent in women as well. And again, that may partly reflect some of the psychosocial and cultural expectations of how a woman goes about in the world compared to a man. Sweating kind of tends to be more accepted in men and less accepted in women. So sometimes these things reflect the expectations on people rather than a differential symptom impact. This is a point that I sort of made earlier, that non-motor function, so some of these other features, declines in healthy aging. Actually, healthy women and older people are more at risk of non-motor symptoms independent of Parkinson's disease. The protective effect of estrogen declines during and after menopause. autonomic dysfunction comes up during and after normal menopause, and that kind of overlaps a lot with Parkinson's symptoms. And like I said earlier, the non-motor burden and effect on quality of life is higher for both sexes. Interestingly, this is kind of really just interesting, but a study looking at men who had male type and women who had women type personalities versus androgynous, a mixture of men and women type personality features. Androgynous people tended to have significantly better quality of life coping with Parkinson's disease. And I found that kind of an interesting factor, and probably reflects the fact that some of the symptom experience reflects the cultural expectations on men and women respectively. And if you move between those worlds, you're less restricted by some of those expectations. Okay, so what do we know about treatment and response of Parkinson's disease for women? There's a higher risk of motor fluctuations, like I said, in levodopa-induced dyskinesias for women compared to men. And so overall, we should probably be aiming to have slightly lower doses of levodopa, and thinking about that early in the piece and thinking about modifying treatment to ameliorate that problem. We're a lot more careful about using dopamine agonists, partly because they have a significant association with impulse control disorders, but that's actually much more common in men, and so the relative benefits may be different for women compared to men. Quite a lot of women report a cyclical pattern in their motor and non-motor symptoms, particularly when they're still getting regular periods, so when that's kind of more predictable, but there's not really good data about whether adjusting levodopa doses during the hormonal cycle is helpful. That probably more reflects a dearth of data than data saying it doesn't help. We probably just don't have enough data to figure that out yet. And oh yeah, this is kind of the point I made above, that actually these different profiles of symptoms and side effects mean that actually we should be probably adjusting treatment in different ways, and maybe thinking about trying different treatments is helpful for different people. Importantly, women are much less likely to be referred for advanced therapies, including deep brain stimulation, even though there's an equal benefit for men and women of these advanced therapies. And in fact, women may get a slightly better quality of life improvement compared to men. That probably, again, reflects a combination of things: patient priorities and physician. This is a not particularly helpful donut, and I say that because the vast majority of the donut is for EMR-guided focused ultrasound, which is not available in New Zealand, and then levodopa carbidopa intestinal gel, which is also not available in New Zealand. But you can see here that the vast majority of people who get EMR-guided focused ultrasound, which is a non-invasive treatment targeting tremor only, the vast majority of these people that get this treatment are men, even though women have a slightly tremor-dominant presentation. Or levodopa carbidopa intestinal gel, so that's like levodopa tablets, but it's in a gel form, so it's got much more consistent absorption from the GI tract, but requires a jejunal tube. So it's run through a pump directly into the intestine. Is offered more to, or is received more by men than women. Deep brain stimulation is received way more by men than women. The only advanced therapy that's relatively similar between sexes is the continuous subcutaneous apomorphine infusion, or apomorphine, which we do have available in New Zealand, which I think probably we reflect that we offer it to men and women relatively similarly. In my extremely scientific approach, I Googled DBS. These are the pictures that came up. And I think this is really interesting to think about, because if you just look at those pictures, there is one of those pictures that is designed intentionally to engage men and women. And that's this one here that's got hair on the person. And I think if you think about, gee, someone's just told me about implanting an electrode into my brain, that feels a bit scary, let's have a Google. None of that immediately is intended to engage women. And that's particularly relevant, I think, because there's also good data suggesting that the way men and women approach decision-making about anything, but big medical interventions, is actually a little bit different. Men tend to like stats more. Women tend to like a story that they can relate to. And once they've engaged with that story, are more likely to hear the pros and cons and the numbers. And so if you change one word, you add women, then you get lots of images that show you not only a slightly different approach, so there's a number of stories there of human interactions, but there's also a number of images here that are directly aimed at trying to engage women. And I think that that's really important when we're thinking about the way we offer and design information and education for people. And I think that extends, not just to advanced therapies, but I think that's a really important example of that. So when we think particularly about deep brain stimulation, and we've got relatively limited access to this in New Zealand compared to many other countries. There's a fantastic service. There just isn't an awful lot of people doing it. But when we look at DBS, women are underrepresented, dramatically underrepresented in DBS cohorts, and that's well beyond the difference in prevalence between men and women that we looked at the beginning. There are less women referred for DBS, and when women are referred, they tend to have had a longer disease duration and more severe dyskinesia, i.e. they've got worse Parkinson's before they get referred. Reflecting that, there's a higher acceptance rate for women who are referred to be offered DBS. So the women who are referred are being referred entirely appropriately, and almost all of them are being accepted. It's more common that women are declined for neuropsychiatric symptoms, mainly depression. That probably reflects a difference in the tendency for women compared to men to get more depression and anxiety, which can be limiting in terms of surgical recovery. So it's not an unreasonable, it's not mild depression, but where it's severe and significant. Interestingly, even after women are referred and accepted for DBS, there's a lower rate of women receiving DBS. So they're accepted, but they don't take it up. And again, that gives us reason to think, why is that the case? What are the factors that are making it more difficult for women compared to men to go through with DBS? Is it just they don't like the idea of it? Or in fact, are there structural factors like they have dependence, or they don't have a support person, or no one's there to care for them after the surgery or transport them to and from? And I think those are really important things to tease out. Men and women who go for DBS have slightly different motor and non-motor profiles. That reflects what we were looking at before, the slightly different presentations in men and women, but they get equivalent benefit from DBS in terms of non-motor and motor symptoms, quality of life possibly slightly better in women compared to men, and then the amount of drug that they're left on, the levodopa equivalent daily dose. And so you can see there that there's differences in the areas that men and women might improve. And interestingly, women get improvement in attention and memory, although men tend to have more cognitive symptoms related to Parkinson's. And that probably reflects the fact that it's kind of not not too advanced, and so there's some reversibility to the problem. And this is really just reiterating that point that there's probably equivalent benefit, although in slightly different realms. For women, the benefit of DBS may not last quite as long as for men. And like I said, cognition might get a bit better in women. Impulse control is more problematic in men compared to women, and can benefit. But mood, quality of life, and the ability to do daily activities of living is equivalent. Women are more susceptible to voice deterioration. So they have a higher voice. They tend to have less muscle bulk and voice problems as a side effect of DBS is a not uncommon side effect related to where the electrodes are implanted and the field of electrical stimulation. But that tends to be a problem that affects women more than men post-operatively. And this is really just reflecting what I said, that actually this means we need to be thinking about having clear direction to people who are holding the access to DBS and other advanced therapies, that we need to be proactively offering this to men and women, not waiting until women are worse before they get offered. We need to make sure that we've got accessible information about DBS that's inclusive, that attends to different ways of thinking about decision making that women and men tend to have, and that information is accessible for people to both individually but also within their community to build an understanding. We need to improve access, physical access. So in New Zealand, it means going to Auckland for preparation for the initial session for the implant, and then going backwards and forwards for the initial programming. That requires quite a lot of support that men are more likely to have than women. And we need to, we also need to build out the research and create systems that are inclusive as a national policy. This kind of segues nicely into what I'm about to say here. So I said earlier, women have disproportionate caregiving responsibilities, not just in Parkinson's, but in life. And that often creates a situation of competing occupational and personal demands. And interestingly, when men receive a major health diagnosis, often their roles and responsibilities are altered by that diagnosis. In Parkinson's disease, when women receive a diagnosis, there's no evidence to suggest that roles and responsibilities are ameliorated. So there's sort of the same expectation of women to perform in all of their roles despite their diagnosis of Parkinson's disease, whereas men in their more commonly physical labour function job are alleviated of that role. And so their requirements of function alter substantially with the diagnosis, whereas those requirements of function in women don't alter with the diagnosis. I found this quote kind of interesting, and it sort of reflects that. Although I realise that getting this disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. That's just really reflecting that fact that none of those roles or expectations of that person have changed with the diagnosis, and so they're left to struggle forward with actually what sounds like too many jobs already, but actually with impaired function, and so that can be really challenging. And there's good data to support the fact that there's a higher incidence of relationship strain and relationship breakdown when women have a chronic disease diagnosis and specifically Parkinson's compared to when men do. And that probably reflects the fact that there tends to be less psychosocial support and caregiving resource available for women compared to men. You're probably all familiar with the fact that life expectancy for men increases if they marry and for women decreases if they marry. And the same is true about informal caregiving. Married men with disability are more likely to receive informal caregiving within their relationship. Married women with disability are less likely to receive informal caregiving within their relationship and therefore, have an increased probability of needing a paid caregiver. They're also usually more financially restricted than the men, and they also tend to have a longer life expectancy than the men. So that actually creates a situation where there's a much greater financial demand on most women, where care is usually not completely subsidized in any society, including ours. So these things kind of compound a little bit for women over time as well. Separate to Parkinson's, caregiving roles are known to associate with increased psychological distress and to have impacts on decision making around an individual's own healthcare. And there's a very well recognised tendency for caregivers to deprioritise their own health and adapt to disability rather than take time out from their caregiving role. They tend to have more poor health themselves, more difficulty accessing care, and an increased risk of depression. And those things are probably really important to think about when we're thinking about why women may or may not access certain types of care, and in particular advanced therapies. This is a visual summary of that article that I referred to at the beginning, where there's also the podcast, and it's just talking about motor, non-motor, and psychosocial issues in women compared to men, and it's quite a nice kind of visual summary of things. I haven't put through this a lot, but because image tends to be a much more important factor for women's life in general, the impact on their self-image and their experience of femininity is often significantly affected for women with Parkinson's as well. And I think, interestingly, the facial masking is experienced more significantly and more commonly by women, and that probably in part reflects the fact that there's a greater expectation placed on a woman's appearance. So those are all things related to Parkinson's that affect both men and women, but probably differentially. There's obviously, I'm conscious of time, a bunch of women-specific things. And I said earlier that women do tend to report, who are still menstruating, do tend to report variation cyclically in terms of their symptoms, and that correlates with changes in estrogen levels. But like I said, there's conflicting reports of whether altering levodopa doses helps. About 5% of women are diagnosed below the age of 40. So they'll still be menstruating, which is kind of tricky to manage, especially if you have a significant tremor. And it also means managing treatment through hormonal fluctuations. It also means managing contraception and managing pregnancy where it's relevant. Many women experience premenopausal, perimenopausal worsening, which probably reflects that additive autonomic dysfunction effect. And there's really very little good data about whether about what we should do for hormone replacement therapy for women with Parkinson's disease. But there's emerging data to suggest that it often improves symptoms for people and has a material impact on reducing levodopa dose, so it's probably good. And it can also benefit some of those other autonomic and non-motor features that are common and overlap: sleep, mood, daily function, cognition, and behaviour. So probably really important, but really there's not really good data to support how we go about that. And like I said earlier, understanding those factors is probably really important because there's conflicting data on, estrogen only versus combined HRT and whether it has impacts on Parkinson's disease severity. So really important areas to get more information about. Pregnancy is relatively uncommon, but actually increasingly common as there's an increasing incidence of young onset Parkinson's disease and an increasing maternal age. So we're going to see more pregnancy. The information about pregnancy is appalling. There's literally case reports and case series. That's kind of the least reliable sources of evidence. But there's good efforts now to try and remediate that. So most women are better on treatment and most women are treated with levodopa. And there's probably an increased need for levodopa from about mid-pregnancy onwards as the woman's volume of distribution increases as she grows the baby. There's about half of women who get pregnant are relatively stable in terms of motor, non-motor symptoms. A small fraction report feeling better, but about a third or slightly more than that experience worsening motor and non-motor features during pregnancy. And that probably reflects a number of things, including a relative increase in volume distribution, so relative decrease in the effective drug a person is receiving. Parkinson's doesn't have to dictate how a woman should plan to deliver, although it's obviously important to keep women well from the perspective of their Parkinson's through the delivery period, which might mean having dosing out at regular times so that motor function is good. Certainly if it was anything like my deliveries, the middle of the night is not the time when you're most on and you probably need to be. There's no suggestion of increased complications relating to pregnancies, although there is an increased incidence of postpartum depression, which is a common problem and increasingly common for women with Parkinson's. Levodopa monotherapy is most commonly used. That's cinemetal-metapar. Dopamine agonists are probably fine as well, and there's a number of medications that we shouldn't use. Interestingly, DBS is probably a good option, particularly for women with young onset Parkinson's, because it both reduces the amount of medication people need to be on and gives them option for managing Parkinson's kind of independent of risks to the developing fetus. But there's really very little data, like I said. And the other thing that we don't really have enough information about is whether pregnancy has an effect on Parkinson's. That sort of sounds funny to think about, but actually there's a huge amount of brain remodeling that happens during pregnancy that you can see on volumetric scans. You can see, this is terrifying, changes in your brain structure as a result of pregnancy, actually not only in the woman, but also to a lesser extent in their partner. And a lot of this is related to estrogen and progesterone, which we know have important roles in terms of dopaminergic function and in regions relevant to Parkinson's. And so it's entirely plausible, actually, that some of that remodeling may positively or negatively affect the course of Parkinson's disease, but we don't have any data that tells us whether or not it does and how that association might be. So there's a need for a lot more data, and there's actually in the last couple of years there's been 2 large pregnancy registries started for people with Parkinson's disease in North America and in Europe. And I think that's essentially how we've got a lot of our information for people with epilepsy. You can't kind of randomize people to epilepsy drugs or not if they don't have epilepsy, so we have to observe many people over a long period of time, and equally you can't randomize people to receive Parkinson's drugs in pregnancy if they don't have Parkinson's, and so you need to acquire a lot of people with this condition over time. to understand how different factors might affect the pregnancy and the Parkinson's. And so that's now the scene is set for that data to be collected. And that's partly reflecting this movement disorders of the International Parkinson's Disease and Movement Disorders Society. And Alexander Len, who's the first author on this paper, is actually in the Sunshine Coast. That reflects some of their work to try and build more information around it. And there's some guidelines that do exist on the basis of essentially expert consensus rather than there being a lot of data. But that's quite helpful information, and also about what we can use in pregnancy and in breastfeeding for women with Parkinson's. And like I said, as well as understanding the impact of Parkinson's on the pregnancy, understanding the impact of women's health-specific factors on the severity of Parkinson's disease is important. And so perinatal depression is associated with an increased severity of Parkinson's disease. Whether that's causal or whether that reflects probably early changes of Parkinson's affecting mood is not clear. Interestingly, natural vaginal childbirth is associated with increased severity. Again, it's not clear why that is or what the association is, and a total hysterectomy, which may link back to what I said earlier about HRT following hysterectomy. There's also some non-sex specific associations, but depressive disorders got an association with increased severity. The LRRK2 genotype, which is a particular gene type of Parkinson's, it usually actually is considered a little bit like garden variety Parkinson's disease, tends to have increased severity in women compared to men, and B12 deficiency, so make sure your B12's good. So I feel like we've done a rapid looking at Parkinson's disease across the spectrum, and I began with an image of Parkinson's disease from 1886, and I was very pleased to see that there's a study in 2020 saying, hey, look, we need some updated pictures that represent Parkinson's disease more generally, because this image represents one type of Parkinson's disease in one group of people, but it doesn't represent the spectrum. And so this I thought was quite cool, showing sort of a milder form of Parkinson's disease, an intermediate form of Parkinson's disease, and a more advanced form of Parkinson's disease. So just kind of giving us that mental heuristic or that visual representation of Parkinson's being different for different people, and helping us to think about that differently for different people, and remembering that women are not small men. So we should be thinking about, and we should be prompted to be thinking about, and we should be advocating for women being thought about and managed differently. So thinking about those different symptom presentations, symptom descriptions, priorities when people come seeking care, and the approach to recognising and managing symptoms, adjusting dosing to an individual, being proactive, offering advanced therapies, and then thinking about specific comorbidities, like I talked about osteoporosis, thinking about the perimenopausal period, thinking proactively about pelvic floor health, which is a much bigger issue than Parkinson's disease, but it's particularly important when Parkinson's causes significant genitourinary dysfunction. Thinking about early nutrition for women as well. We tend to be lower body weight, and maintaining body weight is really important. And then tailoring our physical therapy, and especially thinking about falls prevention. I think it's really important to say that, so there's kind of the medical aspects, there's also self-care and lifestyle approaches that need to be tailored to women. This paper also had some really nice educational resources for people with Parkinson's disease that I would encourage people, if they're interested, to have a look at. And as well as addressing women's needs, I think it's really important that we recognise that some of that psychosocial roles in society means that men don't automatically absorb the information they need to be able to provide caregiving support. And you've probably heard the story, Andrea, but my mum died not that long ago, and my sister needed an operation, and my father then was the stand-in help. And before he left she's overseas, before he left to go and stay with her, he said to me, I'm not too sure that I'm going to be very good at this. I don't really know if I'm going to be able to manage her wound. I was like, Dad, you don't need to do anything with her wound. You're basically the tea lady. You need to make her cups of tea, and you need to drive her to her appointments. It really struck me that actually, his role had been working, providing, there's the things that he thought about and just automatically absorbed in day-to-day life to understand how he would perform those roles over his life did not include caregiving. And suddenly when he was faced with caregiving, this thing that seemed really automatic to me was really foreign to him. And so making sure that we've got resources that help men and women to understand both perspectives, and give people enough information to have some confidence to be able to offer. And actually, some of what he needed was permission to be in that role and to learn how to do that role. And if we can provide that in talking to people and talking to friends and talking to our partners, then actually that puts everybody in a better position. Yeah, I think these are mainly reiterating the points that I've made earlier. And there's a really good initiative by the Michael J. Fox Foundation, who fund a huge amount of Parkinson's disease research globally to promote diversity, equity, and inclusion, which has probably now been crossed out, but to promote people being involved. And I mentioned earlier that actually when there's competing priorities, women often deprioritize their own health, and that is also true when we're thinking about research. And so one of the reasons that women are less represented in research, even when inclusion criteria try and recruit men and women, is that actually the competing priorities mean that having the capacity to be able to engage with research is more tricky. And so part of what we need to do is design research that women can participate in easily, so that we can fill the gaps. And so I think that podcast that I talked about is fantastic because it's questions driven by women asking, this is what we want to know. And that's also much more likely to engage people in research when it's available to them. And I'm not going to linger here, but that's really just talking about all of what this talk is about, that actually thinking about sex and gender to make care better for people with Parkinson's and more tailored. And I wanted to finish with this picture because I think it's a really good example, not just of women, but of all of the different roles that we juggle. And actually, whenever we're thinking about someone with Parkinson's, none of us are just one facet. We've all got these multiple roles and things that we're juggling in our lives, and being able to be more clear about the different things that affect the way our day-to-day goes, and to receive the help that we need to help our day-to-day run smoothly is important. So I don't know if there's capacity for questions online or if we're doing that via the chat, but I'm very happy to answer questions. I'm also conscious that we've run a bit over time, so people may need to run away. And thank you for listening.
I can't see any questions from my side, Eloise, but look, thank you so much. This is such a massive talk. There's so much material. So the good news is that we have recorded this and it will go up on our YouTube channel by next week. So for people that have been watching and for people that have missed the talk, then you're able to go onto our YouTube channel and have a look. But we thank you very much, Eloise, for your time and expertise. As always, fantastic, and lots of things to think about. And boy, we're not doing enough probably. But thank you so much. It's been a real pleasure.
Pleasure to be invited, and yes, I'm very happy to.
Thank you.
Thank you.